Sure. Okay, so hi everyone, I'm Anthony. I am an addiction but also a CL psychiatrist. In terms of what I do for work, I split my time between public, private, and a bit of research. So I work in public as an addiction psychiatrist at Forensic Care. I'm doing CL psychiatry at Western Health, and I also do private work at the Melbourne Clinic. I do some research with the unis you can see at the bottom there. I've included my email, so if any of you have any questions that you would like to ask after the talk, feel free to get in touch. But today I thought I'd do a presentation on private practice and addictions. So why am I giving this talk? Really, I remember when I was doing ADEP and doing addiction training, I was always quite interested in the world of private work, but I didn't really know much about it. And a lot of my supervisors actually didn't work in private, they were fully public. I didn't have any exposure to private practice during my training. I had questions I wanted to ask, but no one really to answer them. And I kind of had to learn things for myself. So I was thinking it might be useful for you to sort of hear from someone who does work in private about what this is all about. Private practice is a significant area of need, particularly in addictions. The demand is huge in private addictions. Just where I'm working at the Melbourne Clinic, in terms of all the referrals that come through each day, the referrals for private addiction admission are 3 times that of general psychiatric admission. So there's huge demand. It is very rewarding, very diverse range of work that can occur in private practice. I'm happy to share all about it with you today. And also I'd like to leave some time for you to ask questions. I'm pretty open with things, so any questions you have, feel free to ask. I asked Vicky to help me share a little poll with you. It's just to, out of interest, I'd be keen to
Oh, we've lost your audio, man. There we are.
Great. So I might get you to answer that. And hopefully we'll see the responses. The responses will come soon, is it?
You can see everyone starting to click through, so we'll give you 10, 15 seconds just to log your choices because there's 3 questions there. So trainees who've just come through the waiting room, we've just got the 1 session today because Alex is unfortunately unwell. So we're going to reschedule Alex's talk as well as Nuru's from the other week to next rotation. So we've got Ant stepping in early and then you'll all get an early mark of 3:40.
So while you're all answering that poll, I'll give you a brief overview of what I'll be talking about today. I'll be going through how we do need more people working in private in the addiction space. I'll be providing an outline of what sort of work is out there for a private addiction psychiatrist or addiction specialist. I'll give my experience and what I do. I will talk about the money in private practice, because I think this is something that people often do want to ask, but maybe are a bit afraid to approach someone about it. And I'll provide some of my own reflections on working in private practice.
All right. Let's get the answers live. So I'll end it now.
Okay.
So for the benefit of recording, question 1, have you had an experience in private addictions work during your training? We've just got 10% of yes, and we've got 38 people online today. Are you interested in doing private addictions work when you finish training? We've got 84% yes and 16% no. What sort of addictions private work would you be interested in doing? Pretty much fairly even, but more outpatient work at 33%, and then inpatient work 23%, unsure 37%, 7%. Again, I don't want to do private addictions work. So.
Great. Okay. Well, it's sort of what I was thinking would be the answer, which is great. And we'll continue on with the talk. So thank you for doing that. So just a bit of background. Look, the government doesn't really record too much detail about service use in the private setting. There's lots of information available about the public sector and hospitalizations, etc. But in terms of private work, there's not too much data out there. But I can fairly safely say, I think that the majority of mental health and addiction treatment is provided in the private setting, whether that be by GPs, by outpatient psychiatrists, or by residential facilities. We only need to look at how many more private rehabs there are than public rehabs to know that this is the case. Unfortunately, with public services, even though they do a great job, they only cater towards quite a small percentage of the population, and often they're focusing on acute management only. I really know during my training, and this was based in Victoria, that in order to access outpatient public clinic, you really needed to have quite a significant opioid use disorder and requiring ORT. Otherwise, you really wouldn't be able to get any care in the public setting. It really depends on the service, but I believe that's very much the case for many of the specialist public addiction services. Because of that, you do lack some exposure to things such as long-term management of alcohol use disorders, which is, I know, an EPA for you. You get less exposure to other substance use and some of the more mild or moderate severity substance use disorders as well. There is a growing need for private specialists. Data has shown that hospitalizations to private mental health facilities are increasing, while hospitalizations to public services are decreasing in proportion to population growth. So this is just some data from the AIHW. We can see that over time, this is in the green line, that overnight hospital admissions per population have increased over the past 10 years in the private setting, whilst in the public setting it's decreased, really emphasizing the need for there to be more people working in the private setting. And in terms of the number of days that patients stay in hospital, that's increasing in the private setting and over time has decreased in the public setting. In terms of what sort of cases are seen in public and private, I know this might be quite small, but we've got here at the top in private hospitals the most common diagnosis seen in overnight hospital stays. So in the private setting, you can see that depression is the most common reason for an overnight hospital stay. And then right up there is mental and behavioral disorders due to alcohol. So I think that's sort of the third most common diagnosis seen in the private hospital setting, and second is stress-related disorders. Whereas in the public setting, the most common, unsurprisingly, for hospital stay is schizophrenia, followed by depression. And if you look at mental behavioral disorders used due to alcohol, that's sort of further down. I think that's way down there, but mental and behavioral disorders due to psychoactive substance use, that's the fourth most common. So there are some differences in the types of cases that you'll see in public versus private. Look, there's lots of barriers to accessing public healthcare. I'm sure you're all familiar with how difficult it can be to get a spot in the public detox and a public rehab. There's long wait lists. There's often quite onerous admission requirements. Whereas in private, often the wait lists are shorter. There can be less barriers. And because of this, the demand for private hospitals are huge. Unfortunately, and I think the poll has emphasised this, there's very limited exposure to private practice during training. It's only 10% of you have had exposure. So one of the previous ADEP trainees, Dr. Kun Kwok, he's now an addiction psychiatrist. He, as part of his scholarly project, he did a survey asking addiction psychiatrists in Victoria about what they do for work. And this also included addiction trainees and what they intend to do for work. So in terms of, and again, this might not be fully representative of every addiction psychiatrist, but in terms of this survey group of addiction psychiatrists, the majority of them work in public community mental health services, followed closely by private, not closely, sorry, followed by private outpatient clinics. So 35% of addictions psychiatrists worked in private outpatients, 33% worked in community drug and alcohol services. In terms of those working entirely in private practice, there's only 12%, compared to about a third of the general psychiatric workforce. So these findings really show how many of the addiction psychiatrists working in the public setting, and those that do work in private, this was in an outpatient setting. If we look at the survey results in more detail, we can see that those working in public and private, what the most common workplaces are. He looked into EMCP, which is early and middle stage career psychiatrists, and LCP late career psychiatrists. Of those working in a private psychiatric hospital and private detox unit, about 11% work in a private psychiatric hospital, 20% work in a private detox unit. So a very small minority of respondents are working in those settings. About half of the addiction psychiatrists work entirely in public, and in terms of working both, many more of the early middle career psychiatrists work in both public and private, 37%, whereas in the later stages of their career, only 15%. So again, it just shows that the balance is more towards working in public settings. So what does private addictions work involve? Look, it's very varied. Now I'll run through, I guess, the main categories of private work. Sorry, I can see some.
We've got a question in the chat, eh?
Yeah, sure.
The nurse just wants you to clarify how many years of practice post-fellowship makes a psychiatrist's late career.
Yeah, I don't quote me on this, but I recall, I think it was 10 or 15 years post obtaining fellowship. Yeah. So in terms of major categories of work, firstly, there's outpatient work. There's a private addiction specialist. So this work is very varied. It can range from providing once-off assessment and management recommendations. So for psychiatrists, you might know this as a 291 assessment. There are, I believe, billing codes as well for addiction medicine specialists. For this, I'm often asked to do shared care with other specialists, where they might just ask me to provide an addiction-specific treatment recommendation for their patient who they're seeing for other psychiatric issues. A lot of the work is continuum care, where you treat a patient longer term for their substance use disorders. I will have to say, though, that as an addiction specialist, really it's important to either yourself be able to admit someone for detox or have colleagues that can do it on your behalf for your patient. It's really, really difficult, as you know, to really have any meaningful change if someone is actively using substances without any period, off their substance. I guess the other interesting sort of work, and there's plenty of work for this, is medical, legal, and expert opinion work, which is otherwise known as an independent medical assessment. Some examples, that I've been involved in is like return to work plans. Many big companies will have, a drug and alcohol policy. If someone during random drug and alcohol testing is found to have a positive result or have self-declared drug and alcohol use, often what will happen is they're stood down and they are unable to return to work unless they first see an addiction specialist and then get an opinion and treatment plan from there. There's work available in workers' compensation in Victoria. It's called the Transport Accident Commission for opinion about whether their substance use disorders developed as a result of the workplace injury or the transport accident injury they sustained. There's work in providing opinion with regards to sort of impaired practitioners or other professionals. I'll outline later my experiences with working for CASA, which is the Civil Aviation Safety Authority. And there's often plenty of work available as an expert witness for both the civil and criminal courts. So examples that might be asked of you is to provide an opinion as to whether someone's level of intoxication may have meant that they could not make sound judgment in the act that they did, which is subject to the criminal court. So it's very, very, very type of work. I think the most common type of work done would be continuing care, and it can very quickly build up. As you know, addiction's a chronic, relapsing, remitting illness. I found that over time, the majority of my workload has been for continuing care patients. The other type of work that the addiction specialists do is inpatient work. So this can take place in many settings. I guess the one that most commonly addiction specialists work in is private psychiatric hospitals. I'm sure you're all familiar with what they are. Typically, the psychiatric hospitals will have a specific drug and alcohol rehab and detox program, which require addiction specialist input. Alternatively, they may just have a general psychiatric program that might benefit from having an addiction specialist. Often these hospitals will have a medical model of care, meaning that the care will be overseen by a specialist, whether that be an addiction specialist or an addiction psychiatrist, or even just a general psychiatrist. Admissions to these settings and how you get paid is by the private health insurance. The insurance will typically only fund for 7 to 10 day detox program and up to a 28-day rehab program. That's not to say that's set in stone. You can always have a longer admission if required. It often just requires you writing to the insurer and explaining the reasons why a longer admission is needed. As part of the requirements of admitting and looking after patients in these settings, the health insurers do require a few things. They do require that there is a weekly MDT meeting be held, and I know at sort of the place I work at, the Melbourne Clinic, it's an expectation for psychiatrists to attend that. It doesn't take very long. It's about an hour, and there's a lot of opportunity for clinical discussion and professional learning as well. And another requirement is that for every admitted patient under your care, that they be seen at least 3 times a week by the addiction specialist or addiction psychiatrist. There's no sort of minimum time needed to see a patient. Previously, you had to see your patients in person, but since COVID, there's been some new item numbers developed where you can see patients via telehealth, and you will still get paid by the private health insurance for the patients you see. When you do look after a patient, you will usually only get paid for each clinical consult that you do with them. So it's a time-based billing. I'll go more into detail about the financial side later. The other types of private facilities available are other sort of residential addiction programs that aren't in like a psychiatric hospital, but otherwise might be accredited to provide healthcare services, and therefore do obtain support from the government, and you can get Medicare and private health funding for the work you do there. There are also other private facilities that are not medically led and often more AA, NA based or therapeutic community based. Psychiatrists and addiction specialists may work in these settings to provide consultation and assessment and management recommendations. Often they don't provide overall care and management of the patient. That's done by the program in general. But an addiction specialist is asked to provide some support if it's required with regards to things such as detox management or management of other psychiatric comorbidities. And then there are other sort of private settings which are sort of wellness or holistic based. These are the ones you see that there's a big emphasis on healthy lifestyle, healthy diet. Addiction specialists can also work in a setting similar to what I mentioned before in the AA, NA therapy community-based facilities. So in terms of what you typically do as an inpatient addiction specialist, look, I've given the example that's most commonly used, which is that you manage your own patients. So you're assigned a patient, you look after them for the entirety of their detox and rehab admission. You sort of provide medical management of their acute withdrawals, and then provide assessment, diagnosis, and treatment as required. You see them right through to discharge. You work with the MDT team, develop a discharge plan for when they leave. It's within a shared care model with the other clinicians within the team. However, there are other arrangements that can be done. I know there are some facilities where you only provide sort of input as required, like that's what I mentioned previously with some of the facilities. It's only for almost like a consultation or as needed review for a specific clinical reason. I know addiction psychiatrists can be involved in actually facilitating groups and providing group-based work. There is Medicare item numbers available for that actually. And you get paid per patient that attends a group. So that can be quite financially lucrative in some circumstances. What might put people off working in inpatient private settings is the need for on-call. So typically when you are in charge of your own patients, that also means that you're in charge of them for the entirety of the admission, meaning that you're available on call to sort out any issues that may arise, overnight, over the weekend, etc. This isn't as onerous as it seems. I know for me, in the past 4 years I've worked in private inpatients, I've only actually had to come in once to the hospital, and that was for a young lady who had to be isolated due to COVID. She had a relapse of her bulimia. Her potassium was 2.8, and she was refusing to go to ED, so I had to come in and assess her. But apart from that, I've never had to come in to hospital after hours to review patients. I often do get texts and calls for things such as, X and Y have run out of space for their diazepam. Could we please get a phone order? However, having said that, I know there are facilities where the on-call arrangements are shared. So if there's a group of specialists, you can take turns in covering each other's patients for a week, similar to what happens in a public setting. And if you only are providing as needed input and don't otherwise manage overall care of a patient, then there might not be any on-call requirements. Something to add though is that typically if you take a phone call, that's not reimbursed, unlike in a public setting. But having said that, I rarely get calls either. Where I work, we get text messages, typically just asking for medication charts to be rewritten, or if someone wants sort of an additional leave over the weekend. So it's not as onerous as it is in a public setting. So in terms of other inpatient work that's available, you can do private CL addiction medicine or addiction psychiatry. So you can provide consults to other patients in a psychiatric hospital, or even in private general hospital, similar to in a public setting. You can, someone might be referred to you for withdrawal management whilst they're in a private surgical ward, for example, when you see them and provide a treatment and management plan. You can also do outreach work to other, not necessarily inpatient setting, but other health care or accommodation settings, such as supported accommodations, nursing homes, if you have someone of older age, etc. So it's very varied. Whatever that can be done in public can be done in private also. So in terms of what I do, look, I'm an admitting VMO to the Melbourne Clinic. I typically have 4 patients under my care at a time, although that can vary anywhere from sort of 2 to 8. I guess the good thing about working in private is it's very flexible. You can choose how many patients you want to take on and what sort of patients you take on as well. Typically how it works is there will be a referral made to the hospital for someone who wants to come in for either a detox admission or a general psychiatric admission, but they may have substance use issues. The hospital will do an intake assessment where they'll get more information about the substances using, comorbidities, what the patient is after, etc. That will then, the referral and the intake assessment will then be sent out to doctors via email for consideration, and you can accept or decline the admission. You have complete, or I can't say for every organisation, but where I work, I have complete control over the patients I admit. So I go through the referral and I decide what I want to take on. And that's what I really enjoy about private is that unlike public, where you might just see the same types of presentations over and over again, you can look out for ones that interest you. I usually get a bit bored of just alcohol use disorders, so I will take on all sorts of cases. So I quite like the challenge of managing, for example, GHB withdrawals in a private setting. I like looking at substances that are, I guess, more novel, that aren't seen as commonly. So I have seen a number of patients for long-term management of nitrous oxide use disorder and ketamine use disorder. I am quite fascinated by behavioural addictions too, and they're all referrals that can come through. So, you know, when I accept a patient, I manage their care for the entirety of their admission. The staff that work in the hospital I'm at, they're very experienced. Many of them have worked in public addictions. They can manage alcohol withdrawals often better than I am. They're often the ones that are telling me, you know, whether someone needs more or less diazepam to manage their withdrawals. I feel very well supported by the team. There's a good sort of culture. There's a good collegial support. The benefits of working in sort of a big private hospital is that if you ever get into a tricky situation, there's many other colleagues that you can turn to for advice or support. They can come and provide a second opinion. They can provide a corridor consultation, etc. I've mentioned before about the on-call requirements, but it's not particularly onerous, I don't think, for me. And there are ways to get the on-call covered, meaning you speak to another colleague who might be able to cover you. I guess the good thing about doing inpatient work is that you don't necessarily have ongoing care of the patient, so you see them only for their hospital admission. After that, you can either choose or not choose to continue their care afterwards. So it's really good for those people who might travel a bit. I have a friend and colleague who enjoys his travels, so he works mostly in inpatient hospitals. You know, before he travels, he will just stop admitting patients and time, you know, their discharge to when he goes on holidays. So the flexibility is great in that regard. So just a little bit about sort of the type of work that's done in the hospital I'm at. So I work within the addictive behaviours program. So this consists of a 7 to 10 day detox program, a 3-week dual diagnosis program, and a 4-week rehab program. The rehab program that we run is a closed program. So patients often need to be assessed by the MDT as being suitably motivated and psychologically minded enough to complete it, and that's just so that everyone is on the same page and everyone is contributing, and it's the right program for them. It's similar to many rehab programs where there's structured activities and programs throughout the day. There's a big focus on lifestyle interventions. There's a daily walk every day, which is mandatory. If you don't attend that, then you get a warning, etc. You get 3 warnings, you get discharged. I'm sure this is all very similar to what other programs do. It's a big focus on psychosocial therapy, particularly interpersonal therapy within the rehab program. Individual counselling is available as well. What I like about working in a hospital, private hospital, is that there's access to on-site physicians and GPs. There's one on that's available for consultation daily. We have good relationships with our local ED, so any complicated withdrawals can be sent to them. Although we can manage quite severe alcohol withdrawals. I think I've prescribed the highest dose of diazepam actually in my private hospital than I have in public, which is 200 mg of diazepam per day. In terms of when I usually see my patients, I normally see them between the groups, so it's either during a lunch break, which I do on Tuesdays, and otherwise I will see them after my public work on a weekday. So for 4 patients, if I come into the hospital at 5 p.m., I usually be out by 7:30 p.m. after seeing my patients. I get access to a registrar who I believe is attending this talk today, and having a registrar really makes the work so much easier, and you get all the benefits of supervising and mentoring a registrar, and I get sort of billing support from the hospital as well, so I don't need to worry about any of that. I just write down how many times I see a patient, how long for, and the hospital will take care of that. So in terms of what is a private patient, I'm sure some of you may have conceptions in your mind of what sort of people we might be seeing, but actually, like, it's really varied. And it can be, particularly if you've got additional qualifications in addictions, they can be as complex or as simple or as tricky as you want them to be. Many of the patients I see have had contact with the public system. All of them have quite considerable functional impairments and psychiatric and also medical comorbidities. So as part of the scholarly project, some of the registrars at the Melbourne Clinic have been doing some data collection, looking into what are characteristics of patients admitted to our facility. So just to quickly go over it, look, 53, about half is male, half are female. The age range is from anywhere from 18 to 79 years old, but the mean age of 43. Look, 37% do reside in sort of the areas of highest social advantage. But having said that, I'd say the majority of the patients I see, they themselves aren't wealthy. They haven't, they often don't work, or if they work, they don't earn lots of money. Many of them are supported by family to get private health insurance. Many are single, living alone. Only 42% are employed or studying. Look, alcohol use is the most common substance use, but methamphetamines and opiates, close to 20%. So we do see quite a few people for commencement of ORT. Co-occurring psychiatric disorders, look, most common anxiety, depression, PTSD, and personality disorders. Many have trauma history and suicidal ideation. In terms of the outpatient work I do, look, I only at the moment do that half a day to 1 day a week. The rooms I work in, that's provided by the hospital. That includes admin support. Most of my patients I actually get from the inpatient work I do. I think that's a good way of going about it for me, is that you get a good 1 to 4 weeks of seeing someone, working out whether it's someone that you feel you can work with and they can work with you. But in terms of the type of work I do, look, I think it's a mix between sort of once-off opinion and management plans, often from referrals are from colleagues that I know, ongoing care of patients, and some medical legal work. Again, in private work, there's flexibility in what you charge or don't charge. I bulk or reduce bill up to half my patients, and actually I find that those ones are the most rewarding. They're the people that are quite impacted by their substance use. They don't have the money, and the family might not have the money anymore to pay for them, but it's really rewarding to see, after many years, improvements. I do also some expert opinion medical legal work for the Civil Aviation Safety Authority. This is often anyone in the airline industry, most commonly pilots or cabin crew that have been found to have a substance use disorder or have had a positive drug and alcohol test and require a treatment plan from someone like yourselves. But also if I've provided some opinions to the courts and other organisations, such as the Workers' Compensation Scheme. So in terms of what I find the benefits of private work are, look, it's very highly rewarding. Patients really do get better, and you can see them get better. Often we don't get to see that during training because we rotate through services. We only spend 6 months somewhere. We don't see sort of long-term progress and improvements, or you never get the ability to see people for long-term management due to the restrictions of what's accepted in the public sector. I'm never bored. If I get bored of a certain presentation, then I can just look for other ones. It's really rewarding to have patients, really value and take on your advice and your expertise. You're not restricted to a specific sort of age range, which I quite enjoyed. I really enjoy seeing and keeping up to date with knowledge in treatment of addictions and mental illness across the age groups. So I think my youngest patient is 15 and my oldest is 81. I'm constantly learning, and often I hear from colleagues that they learn the most when they do private, because you often see things that you don't see otherwise in public. But because of that, you're always having to keep up with learning in CPD. There's very good flexibility in work-life balance in that you can dictate your hours, although I put a little asterisk there because it can get too much sometimes. I think there's always a need for your expertise and for your skills, and patients will relapse and you'll get lots of referrals, and sometimes it's really hard to say no. In terms of the challenges, look, I asked some of my colleagues what they thought the challenges were, and many of them said, look, it's tougher than it seems. Like, actually, the most stress and headaches that people will say it's not from public necessarily, but from private. And mainly it's because you have full responsibility for and ownership of the patients. They become your patients. You don't sort of share them with the team. And they're sort of allocated to you. I still get letters from EDs and acute sort of psych units for patients who said that I'm their psychiatrist, even though I've only seen them twice in the past. What's challenging but also enjoyable are these sort of grey zone clinical decisions. In public, we often see cases where it's quite black and white. It's quite clear. Someone definitely needs an involuntary admission, or they don't. In private, it's less clear. You get patients who, for example, might be at risk to themselves or others, but perhaps not to the threshold where they are meeting the need for an involuntary treatment order. So that is a challenge. It can be very isolating, particularly if you work in outpatients on your own. And there is always the risk of burnout and trying to do too much. Particularly in addictions, you'll get people call up saying that they've relapsed. You get family quite distressed and upset, asking you to help their son, their daughter, and it's having, you start off with only 2 inpatients, and that can quickly balloon to 6 by the end of the week, just from previous patients relapsing. You often deal with lots of sort of counter transferences because they become your patients and you get to know them. You often may feel this need to sort of rescue or fix them, and that's something just to be very wary about, as well as anxiety, worry, and a sense of hopelessness and helplessness sometimes. But again, it's a projection of what the patient is feeling, and they're projecting it onto you, but you're having to sit with it and go home with it as well. there are occasionally sort of complaints and grievances that occur, and because you're working on your own, you often have to do all that on your own, although the indemnity insurance that you get can assist with that. There's a need to keep on top of admin, such as letter writing and billings as well. If you have someone that does the billings for you, I would recommend that you double check. All right, so now let's quickly talk about sort of the money and how that all works in private. So in terms of the billing options, look, there is the option for bulk billing. So this is what the Medicare schedule fee is. So this is what the government sets as the rate to give you, and if you bulk bill someone, you do it per item number. So the common item numbers I've listed here. I'll just run through how it all works. So this is for an addiction medicine specialist. So this is for item number 6023. So if you bulk bill this person for this item number, it means that you see them for at least 45 minutes for initial assessment for a patient with at least 2 morbidities. So if you provide an opinion and diagnosis, treatment options and medication recommendations, if you bulk bill them, you get 85% of the schedule fee rate. So you get $265.60 from Medicare. That's if you bulk bill the patient. And that's for the initial assessment for an addiction medicine specialist. This is 6018, which is just a general consultation by an addiction specialist. There's no time limit on this one. If you bulk bill it, 85% rate is $151.90. 75% rate relates to the inpatient if you see them as an inpatient. As a psychiatrist, if you do a 291, this is the comprehensive assessment and management plan that lasts for 12 months. It requires you to provide a formulation, diagnosis, comprehensive management plan, etc. If you bulk bill a patient for this, then you get $455.60. If you do an initial consultation for a patient that lasts more than 45 minutes, you get $262 if you bulk bill, etc., etc. So you can look at these in your own time, but it's worth getting familiar with the Medicare item numbers. Something to know about is the Medicare safety net, where this more applies to gap billings. So this is what most private practitioners will charge, is they will set their own fee. The patient pays that, and then they will seek out sort of a reimbursement from Medicare, which contributes to that consultation. So this is really just a range in which I've seen practitioners in my state charge for sort of a consultation. So it's $500 to $800 for a 45-minute appointment, $200 to $450 for a 30-minute appointment. Something to know is that there is something called the Medicare safety net threshold. So if a person or a family, if there's multiple people on a Medicare card, spend more than $2,700 out of pocket in a year or within a year, then Medicare will cover 80% of the out-of-pocket costs. So for people who see yourself or other specialists quite frequently, they can quite quickly reach the safety net threshold, and the government will pay for a large chunk of the out-of-pocket fees. There are other schemes available that can pay for consultations. So the Department of Veteran Affairs, Workers' Compensations, they will have a set fee that they allocate to pay specialists for a consultation. It does mean that you have to accept the fee that they have set out, but it means that the patient doesn't need to pay anything out of pocket. So they'll pay that straight to your bank account. Similar to if you were to bulk bill Medicare, you register your bank account to Prodo, and you'll get the funds in your account. In private psychiatric hospitals, each time you see the patient, you will be paid via the private health insurance, and that's usually set at 20% above the Medicare schedule fee. So you only get paid for each face-to-face interaction that you do, although there are other arrangements available. I know what's fairly common these days is that psychiatric hospitals will provide a locum day rate for practitioners. So it means that you get paid per day and admit X number of patients and see X number of patients per day. Anything to do with medical legal that's not considered clinical will attract a fully private fee, so Medicare won't contribute to that. Other things to consider though are that there's room and admin fees that you have to pay. Working in private, you don't have any sick pay, holiday pay, superannuation, so you need to factor that in if you aren't paying that to yourself. Other indemnity, insurance costs. You work hard for your money essentially, because if you don't see patients, you don't get paid. Most consults are time-based. They don't increase necessarily the amount that you get paid if they're more complex. I know other medical specialties, if a patient's more complex, you get paid more. It's not the case with psychiatry anyway. I'm just mindful of the time. So I'll quickly jump to this in terms of what would have better prepared me for a career in private. I think all of us, having done our training, will clinically be more than proficient enough to provide good care. But there are some things that I felt I had to learn on the job, and one of those was sort of the long-term management of addictions, the treatment of sort of higher prevalence and lower acuity disorders such as anxiety management, depression, PTSD. I think in particular managing anxiety is particularly important working in private. Often people will be using substances to manage anxiety and emotions, and because of that, I think some training or exposure to psychological therapy would have been useful for me, particularly in structured therapy such as CBT, ACT, etc., as well as psychodynamic approaches to managing. I think I would have benefited from being able to get more exposure to formulating patients. I unfortunately did not get to do too much of that because of how the psychiatry assessments changed when I was training. It changed to an OSCE rather than a observed case interview. And the other thing I would have benefited from is how to write more succinctly, in terms of writing letters and notes succinctly, but that covers enough details. Something to know is that at any point your notes can be subpoenaed, and technically they're the property of patients. So something I've been quite careful of when I started private is what I exactly put in the notes. So what has helped me in private, I think having boundaries, as you know, in addictions is very important, but having said that, you can't be too rigid. There is some flexibility needed. I've learned that being able to contain patients, particularly psychologically without medication, that's really paramount for long-term management of addictions. If patients learn that they can contain themselves without the need to reach for a bowl or get a pill, then they will be able to overcome the need to self-medicate. Having a good MDT network, having good colleagues have really assisted me in dealing with clinical conundrums. And I think the most important thing to drive therapeutic change the principles that Carl Rogers has expressed, which is essentially, look, if you're empathetic, if you're genuine, you're open with your patients, and you provide unconditional positive regard, often that's just what's needed for them to make the change. Um, and as you know, there's not really many medications apart from ORT that are particularly good in addictions. So really being there, being a constant support, managing any crisis, I think that will go a long way. So having said that, look, I think you all have the skills and knowledge, and hopefully you'll have the interest in working in private practice. So I'll leave it there for some questions.
Thanks. Yeah, we'll get you to stop sharing the screen. Always helpful to lift the veil, so to speak, on private practice and what to expect. Because, yeah, a couple of you will end up working in the private sector, and hopefully this has helped you to grasp the concepts a little. If anyone has a question or a comment, feel free to pop your hand up or put it in the chat. We've got Jason.
Hi, Dr. Hugh. Can you hear me okay?
Yes, I can.
Look, we don't tend to have much of a private sector here, and you can tell from my accent just across the ditch. I think it's needed though. I think ours is probably a lot more NGO and public, and there are some private centres, but they're sort of few and far between. It looks great. I was going to say, for you, when I think of your position being private, how do you? I'm envisaging in the public system here, we don't really tend to deal with diagnosis of ADHD. And we get a lot of patients in addiction saying, hey, I've got ADHD, etc. Whereas our public system's really limited, and it just is like, nope, sorry, we're not diagnosing that. I mean, sometimes they'll do it if it's really overt. And do you find with being in private practice that there's a lot of, hey, doc, can you assess me for ADHD as well as deal with my detox from alcohol? And can you prescribe medicinal cannabis? Maybe can we, you know what I mean? Like, is it more kind of people are willing to push a few more things that the public system can put a barrier up against? Thank you.
No, definitely. Like I get that question a bit. Again, in private, you can screen out for that. If you don't want to deal with any of that, you can choose to not sort of admit anyone who wonders whether they have ADHD. But I guess the benefit of particularly working in private inpatient is it gives you a longitudinal view of their presentation, particularly off substances, and you can get collateral information from the MDT team about how they're going in groups, how they are on the ward. There are some patients who are quite clearly ADHD after the detox period because they can't focus in group, they're restless, they're unfiltered, they're overfamiliar, etc. I would say that in patients who've asked me the question, do I have ADHD and that have addictions, I'd say probably half I have diagnosed with ADHD and treated for in the end, and half haven't. But I do go through that comprehensive process, and the ones that I haven't diagnosed, in the end, some of them will say, look, I don't agree with you, but I can see that you've done a comprehensive assessment, you've taken the detailed history, etc., and I respect that. But yeah, look, in terms of the outcomes of patients who have been treated for ADHD, I know often you might hear that there's life-changing outcomes if they're commenced on stimulants. I haven't experienced that, unfortunately. It does improve their functioning a little bit, but it hasn't been life-changing. And I've always been, the focus is on regardless of whether like the severity of your condition, the focus should be less on medical management of your difficulties and more psychosocial. Because if you focus too much on medications, then you'll be looking for psychoactive approaches to managing all of your difficulties. Again, that's just my opinion.
Thanks. We'll go to Olivia.
Thank you. That was really interesting, and yeah, not something that's really covered much at all in our psychiatry training in terms of working in the private system. I was interested that you sort of mentioned about the lack of training in sort of psychological therapies, and I was just wondering, other than ACT and CBT, is there anything else that you wish you'd maybe had more exposure in or training in before sort of working in the private system?
Yeah, look, anything really. Yeah, I think just given if you look at what is most commonly seen in terms of psychiatric comorbidities, it's anxiety, stress-related disorders. So it's anything that has an exposure sort of based cognitive approach to managing stress, anxiety, etc. I'm sure you're aware that often people turn to alcohol and drugs because they can't tolerate their anxiety, they can't tolerate the stress. They use it as a way to avoid rather than sit with that distress. So any sort of type of therapy that you can provide to make them learn that actually you need to be able to confront your difficulties rather than avoid them.
Thanks, Olivia. Thanks, Ian. Any other questions or comments? I'm just making sure I'm not missing hands. I might throw one in just because this tickled my pickle when I did the psychiatry private term as a reg. I worked with a consultant who I hate to say was a bit of a death magnet for his colleagues because he'd had 2 colleagues who died in the last 5 years or so when I worked with him. And then they had to work out what to do with those doctors' patients because these were not sort of planned, foreseen retirements or anything like that. There was one psychiatrist he worked alongside where they actually had to break into the filing cabinet to retrieve medical records, but it brings up a very important point around documentation when you're working in private practice and you don't have systems like, I forget what you call them, but your EMRs and your CPFs and things like that. So if you're working in a clinic or things like that, typically the documents, they go to the clinic and they can be redistributed and things like that. But if you're a sole practitioner, make sure that your medical records and documentation are really stored securely. The rules differ depending on jurisdictions. Like in Australia, in New South Wales, ACT and Victoria, they've got really clear guidelines that for people up to the age of 25, you've got to keep them up to the age of 25. And then for adults, you've got to keep them for 7 years. New Zealand's are even stricter. You've got to keep them for 10 years for adults. But they're the property of the patient. So knock on all wood, if you were to pass away early and the patient wants to seek them, if you're not working in a clinic, it's actually the executor of your estate who's got to release medical records. So hot tip, if you work in sole practice, have a will, talk to the executor of your will. That might be a responsibility potentially, and talk to your indemnity insurance about medical record documentation. But that was a strange thing that I learned in training working in private sector. I don't know if you've had any similar situations, Ant.
Oh, I have trying to get records for patients who have through succession management come through to me. I guess that's the other challenge sometimes of working in private outpatients is once you build up a patient base, they almost become like your children in that you've got to think of what to do if you ever take an extended leave or go on a break. You've got to find someone else to take care of them. So in a way, there's flexibility, but also there's not.
All right. The final take homes, Leanne, if there were sort of 3 top things that you'd want people to know as they venture into private practice, if they're freshly minted addiction medicine physicians or freshly minted addiction psychiatrists in the next year or 2, what would it be?
Oh, look, I'd have to say it's highly rewarding, highly enjoyable, and there's low barriers to entry in the sense that if you want to give it a try, then go ahead. I'd approach some of these private hospitals. There's often no obligation, there's no contract you have to sign and you have to stay on for a year. You can try admitting a couple of patients, see how you like it. They'll probably offer you a free room somewhere to see them ongoing. If at any point you think this isn't for me, then you can stop. So give it a go. And then we need plenty more private addiction specialists.
Good one. All right, if everybody would like to join me in thanking Ant for coming out and presenting to you all, he's got his email on the front slide of his deck or the back slide of his deck there. So if you wanted to reach out to Ant, then yeah, he's very happy to take questions, thankfully. But yeah, thanks for your time, and we'll let you go. And thanks for stepping in and presenting earlier as well.
Right.